Hello everybody. Today we are going to discuss about the case of acute pancreatitis secondary to the hypertriglyceridemia. So we have this 35-year-old male patient with a history of pancreatitis 2 years back, which was treated in outside hospital. Now again he was complaining of abdominal pain associated with nausea, vomiting, breathing difficulty. Initially he was admitted at some local hospital on 4th of May 2024, and his amylase lipase are elevated. Amylase were 200 and lipase were 502. Along with this, the triglyceride levels were 1872. So CT abdomen was taken, which was since this patient was having history of acute pancreatitis and hypertriglyceremia, the first suspicion was towards this pancreatitis. So they have taken CT abdomen, which was suggestive of acute interstitial pancreatitis, hepatomegaly, diffuse fatty liver, and non-obstructive renal calculus. Then patient was because of the breathing difficulty. Patient was started on BiPAP. He was requiring vasopressors and inotropic support. That's why he referred to our hospital for further. On arrival in the ICU, patient was conscious, oriented, afebrile, but he was highly tachycardic. His pulse rate was around 162. Blood pressure he was maintaining of around 104 by 68 on noradrenaline at 10 ml per hour and vasopressin at 2.4 ml per hour. Saturation was 96 on NIV at 50% and respiratory rate was 32. On cardiovascular examination, S1, S2 was present. RS air entry was equal on both sides, and the chest was clear. Per abdomen was distended, and it was tenderness was present in the epigastric region. CNS patient was conscious. ABG we have taken, which was suggestive of metabolic acidosis. His adjective was 544, and the ketone were mildly positive. Now, this all the routine investigation we have sent, and his triglycerides came out to be 1,237. His HbA1c was 9.9, and his amylase was 869. So this was the ECG of that patient. So for this patient, we have started one cycle of plasmapheresis, and the patient was started also on the following medication like meropenem 500 mg IV, TDS, Targocid 200 mg, Hydrocort 50 mg, then tablet Ivabrad, Fragmin 2500, and calcium gluconate IV, TDS. So this antibiotic we have started because the patient was on this patient was hypotensive and on inotropes. Since Ivabrad we have started because patient's heart rate was very high. Fragmin was started because it was a part of because it will help in reducing this hypertriglyceremia, and injection calcium because of the hypotension. So before initiation of the plasmapheresis, his triglyceride levels were 1,400. After one cycle of plasmapheresis, it became 1,237, then 631, 614. So still he was requiring NORAD at 10 ml per hour, which we were tapering according to the blood pressure. He was on dextrose 50% at 20 ml per hour and HI at 10 units per hour. So patients, next day the patient's urine output started dropping. So for that we have given nephro reference, and we have started him on the Lasix. Patient was not responding to Lasix and decision to initiate SLADE was taken. So after that patient underwent 5 cycles of the SLADE. So this was his report. As you can see, the triglyceride levels are coming down. So first day it was 631, then 614, and then 621. And finally it became 414. We will have the discussion on hypertriglyceridemia induced pancreatitis. So what is hypertriglyceridemia? National Cholesterol Education Program categorizes triglyceride level as a normal if it is less than 150. It is borderline high if it is between 150 to 199. It is high if it is between 200 to 499. It is very high if it is more than 500. So primary hypertriglyceridemia is include familial chylomicronemia syndrome, primary hypertriglyceridemia, mixed hypertriglyceridemia, also known as Fredrickson type 1, 4, and 5 respectively. Common genetic defects include lipoprotein lipase deficiency, LPL gene mutation, apolipoprotein C3, C2, and other genes involved in lipoprotein generation. Now, secondary factors are obesity, alcohol abuse, uncontrolled diabetes mellitus, hypothyroidism, chronic renal failure, and drugs like estrogen, corticosteroid, retinoid. Immunological disorders like autoimmune hypertriglyceridemia caused by antibodies to LPL, ApoC2 should be ruled out. Now about pathophysiology, triglyceride levels above 882 but around 1000 should be considered as a causative factor for acute pancreatitis. In 2016, a large population study nicely showed that risk of developing acute pancreatitis starts increasingly at triglyceride level above 1700 77 mg per day. Now, what is mechanism behind it? When the triglyceride levels are reaching around 800, it leads to the formation of the chylomicron. This leads results into the lipemic serum, which increases the blood viscosity and it inducing and maintaining ischemia in the pancreatic capillary bed. So hydrolysis of excessive triglyceride by pancreatic lipase results into the formation of free fatty acid, which is toxic to acinar cell and induces inflammation within pancreas with increased cytokine level. And it is this increased cytokine level is responsible for inducing systemic effects. Now about clinical features. So the patient will be presenting with abdominal pain, elevation of the pancreatic enzyme over 3 times the upper limit of normal, and the radiological evidence of acute pancreatitis. Amylase level at presentation could be normal. This I'm not sure because I have seen only one case of hypertriglyceridemia induced pancreatitis. So and in that amylase levels were elevated, but it is mentioned in the literature that amylase level at presentation could be normal. So serum triglyceride level should be measured as soon as the symptoms start. Now about management, conservative management include aggressive intravenous hydration, initial bowel rest, and the pain control. About severity of the pancreatitis, it is calculated by BSAP score, Apache 2 score, City Severity Index, Ranson criteria, and Atlanta. Now we'll come to the main treatment. So first is insulin. Insulin activates lipoprotein lipase activity, which accelerates chylomicron degradation, thus lowering triglyceride level. Insulin lowers the triglyceride level by 50 to 75% over 2 to 3 days. So intensive insulin therapy was found to lower Apache 2 score after 72 hours of the treatment. Now about role of heparin. Heparin releases the stored lipoprotein lipase from endothelial cell, thus lowering triglyceride level. Combination of insulin and the heparin has been used to lower triglyceride level with the mean decrease of triglyceride level by 50% within 24 hours. Low molecular weight heparin has been shown to lower lipoprotein lipase level similar to the conventional unfractionated heparin infusion. Now about adverse effect of this combination of the treatment of the insulin plus heparin is rebound hypertriglyceridemia. There will be the risk of hemorrhage into pancreas during acute attack on continuous heparin infusion. So heparin should be preferably avoided. And then hypoglycemia. Now the next treatment line is plasmapheresis. So plasmapheresis rapidly removes triglyceride and chylomicron from circulation, removing inciting factor and halting the further inflammation and damage to the pancreas. So most patients require only one session of the PLEX as it is reported to lower triglyceride level by 50 to 80%. So PLEX improve this hypertriglyceridemia induced acute pancreatitis outcome not only by lowering triglyceride level but also by removing pro-inflammatory markers and cytokine to downregulate inflammatory process in this disease. Now about adverse effect. Plasma infusion itself is associated with the risk of infection and allergic reaction to the donor plasma. So, as well as PLEX requires central venous access, which itself predisposed to another set of complications, including but not limited to infection, hemorrhage, and injury to the blood vessel and thrombosis. While the risk is real, reported incidence of adverse effect is low, that is 5.7%. Mainly the blood access problem, tingling, hypotension, and urticaria. In addition, the PLEX is costly and not widely and easily available. In conclusion, it seems reasonable to initiate PLEX in patient with hypertriglyceridemia-induced acute pancreatitis as soon as possible, preferably within 36 hours, to halt further inflammation and necrosis of pancreatic tissue. Most studies have utilized triglyceride level less than 500 to be the end point of therapy. And PLEX should be considered in patients with the severe hypertriglyceridemia-induced acute pancreatitis with Apache score of more than or equal to 8 since mortality rate are high and reported to be around 10 to 39%. American Society for Apheresis considered hypertriglyceridemia-induced acute pancreatitis as grade 2C recommendation. Now about combined blood purification therapy. Combined blood purification therapy is the two-step approach for the management of acute severe pancreatitis involving plasmapheresis and continuous venovenous hemofiltration. Combined plasma filtration absorption combined with CVVH has been shown to improve mortality and lowering of inflammatory marker in severe acute pancreatitis, irrespective of etiology of pancreatitis. Sequential blood purification therapy involve plasma exchange and CVVH has been shown to improve 28-day mortality, ICU stay, and time to target lipid levels in patients with severe hypertriglyceridemia-induced acute pancreatitis. Now about high volume hemofiltration and hemoperfusion. Continuous venovenous hemofiltration is commonly used for severe acute pancreatitis and has shown good results including mortality benefit. However, rules of hemofiltration in hypertriglyceridemia-induced pancreatitis has been recently explored. So its high volume hemofiltration has a role in severe acute pancreatitis with possible inclusion criteria of Apache score more than 15, provided hemofiltration can be started within 72 hours of initial presentation and continued for at least 48 hours. Full benefit of high volume hemofiltration is derived not only from triglyceride lowering therapy but also from removal of pro-inflammatory cytokines. Now about pharmacological therapy. Once the patient can tolerate oral intake, adjunctive lipid lowering therapy should be started with goal of achieving long-term triglyceride control. Consultation with dietitian should be sought and the patient should be counseled on the importance of low-fat diet to prevent recurrence. Lifestyle changes including better diabetes control and alcohol abstinence should be reinforced. Lipid electrophoresis should be done to a certain type of hypertriglyceridemia for any genetic component after secondary causes are ruled out. According to ATP3 guideline, fibrate remains the drug of choice for severe hypertriglyceridemia with niacin as an adjunctive therapy. Fibrate, statin, niacin, and omega-3 fatty acid has been shown to reduce triglyceride level by 36.3%, statin by 10 to 18%, niacin by 20%, and omega-3 fatty acid by 25 to 33.8%. As we can see, fibrates are most effective in reducing triglyceride levels. But the common adverse effects are myopathy, cholelithiasis, and reversible increase in creatinine. Now, fibrate, if combined with statin, it increases the risk of rhabdomyolysis 2 times as compared to fibrate monotherapy, but overall risk is very low. Gemfibrozil is associated with high risk of myopathy as compared to fenfibrate and should not be combined with statin. Interestingly, the fibrate therapy was shown to be associated with increased risk of pancreatitis. High dose niacin therapy is also effective in lowering triglyceride level, but its use is limited by frequent adverse effects like flushing, pruritus, gastrointestinal disorder, hypertriglyceremia, blurring of vision, myopathy, and elevation of liver enzymes. Moreover, it has been associated with increase in plasma glucose level and worsening diabetes. Omega-3 fatty acid are effective drug with good safety profile. Combined medium chain triglyceride and omega-3 fatty acid has been reported to lower triglyceride level by 67% over 1 week period. Medium chain triglyceride do not form chylomicron and when absorbed and prevent postprandial hyperchylomicronemia. Diet contain total fat of less than 15% should be started to prevent hyperchylomicronemia. Non-pharmacological treatment for severe hypertriglyceridemia have been described as mainly this microsomal transprotein inhibitor and lumitapide, gene therapy for hereditary hypertriglyceridemia and LPL deficient individual. As I have already mentioned, these are novel pharmacological treatment and we don't have enough evidence so that we can use in our daily practice. So if I want to summarize, if I am dealing with the case of hypertriglyceridemia induced pancreatitis, then along with the initial conventional treatment, I'll start him on the insulin drip at the rate of 0.5 to zero point 0.3 unit per kg. So while the patient is on insulin drip, I have to be very careful about his blood sugar level, and along with insulin, I'll start him with the dextrose in case of hypoglycemia. So along with the insulin therapy, I'll also start heparin, but please remember heparin infusion is not recommended. Then I will categorize the severity of the pancreas. If I found Apache score is more than 8, Marshall scores are more than 2, multiple organ dysfunction is there, biopsy severity index is also high. Uh, uh, in short, if I want to, if in short, I want to, what I want to say is, if I'm dealing with the severe acute pancreatitis, then I will be starting with the non-pharmacological therapy like plasma exchange. So if plasma exchanges if is apheresis or plasma exchange is available, can then the next question is, can patient tolerate apheresis? So if the patient can tolerate plasmapheresis and if there is no contraindication for plasmapheresis, then I'll start the plasmapheresis as soon as possible. As I mentioned before, the effectiveness of the plasmapheresis is maximum if we initiated within 36 hours with albumin as a replacement fluid and citrate as an anticoagulation. And we need to continue the plasmapheresis till triglyceride levels are less than 500. If the plasmapheresis is not available and if there are contraindication to plasmapheresis, then there are alternative therapy like CVVH with HP if available. Consider continuous venovenous hemofiltration with alone if HP high volume plasma is not available. Then if the pancreatitis is not severe, then continue with the conservative therapy. Continue insulin infusion until triglyceride levels are less than 500 and then look for the signs of organ complication and dysfunction. If there are no organ complication and dysfunction, then start with the fibrate, as fibrate is the drug of choice for long-term triglyceride control with omega-3 fatty acid as a reasonable second choice. Niacin and statin can be added, but combined adverse effect. Uh, but combined adverse effect, they are not well tolerated. Then more treatment options of hereditary lipoproteins are currently being explored. Thank you, guys.